Okay, well, you guys tell me about pulmonary disease. Alyssa?
You can get it from smoking.
Yeah. What else can you get it?
How else?
Yeah. Yeah. Yeah, there's actual, you can actually get emphysema. There's a genetic disposition for people to have emphysema. That's even not due to smoking. So, big thing here they want to talk about is with pulmonary disease. Usually, want to break into three categories. You know, is it one of these three things, or is it a combination of these things? Is it a ventilation issue, a diffusion issue, or a perfusion issue? What do you think the ventilation? What do you mean by ventilation issue? Mechanical, tidal volume. What else? Obstruction, not obstruction. Again, we're talking about just the pulmonary circuitry at that point. Is everything moving and flowing at that point? What about diffusion? Yeah. What can inhibit gas exchange? Fluids. Yeah. Anemia. So. And what about perfusion?
Shock? Shock? Lung shock?
Yeah. Basically, why are we not offloading, or are we able to offload? You know, offload. You know, O2 CO2 thing. It's just idea. Again, it's kind of like, you know, what's happening, what's causing what, or is this a combination of? Is what they kind of want to get you to look at this. So again, with ventilation here, we're kind of looking at the actual, again, pulmonary circuitry. And we always break in the airway between upper and lower. What's our landmark? That
Starts with a C. Is this a landmark?
that divides upper and lower airway.
The current?
Yeah, epiglottis. The epiglottis. So, and the big thing they want to look at is this with upper airway ventilation is, you know, why are we not moving air for whatever reason? Is it a traumatic issue? Are we having an angioedema issue? You know, a foreign body airway?
Like laryngospasm?
Yeah, laryngospasms. I mean, what's the cause there? Because, I mean, obviously we got to figure out, if we know what the problem is, where it's starting, where obviously gives the direction how we're going to fix it at that point. Versus lower airway, again, we kind of have a little bit of a change because obviously we can't really just dig in there. So we kind of have to kind of, you know, approach this with a little bit more of a indirect manner. Obviously with trauma, we're kind of limited because the structure's already been compromised at that point. Versus lung disease, something that's already been in process. And with lung disease, you got to remember this is a lot of remodeling of the lung, as ironically as it may sound. But, you know, for example, with the people who are smoking or exposed to cold or whatever the case may be, the lung is actually trying to be remodeled to the environment it's been exposed to. Mucus accumulation, again, that can be prolonged lung disease. It can actually also be various, you know, like CS gas, for example. Smooth muscle spasm, asthma is your big one there, and airway edema. So what's our mindset and how to fix this? What are ways we can fix these things? Intubation. Okay, what else?
Removal of foreign body.
Move foreign body, drug. What kind of drugs?
Yeah,
Epi is, yeah. What about this?
I mean, I know it's not really.
Oh, well, I mean, if it's causing an actual obstruction, how are we going to deal with it? Yeah, you can do that too. That's an answer for everything.
I mean, like, not for us, but I mean, like, a doctor can remove it tonsils.
Yeah, but I mean, for us, I mean, if we actually have really bad inflamed tonsils, I mean, what?
Positive pressure?
Positive pressure, tube them, or, you know, in case we got to clear that, you know, passageway. Here's where it gets a little bit more trickier. And like I said, obviously we're kind of looking more of, we're almost kind of looking at indirect, kind of almost an indirect means for, I mean, obviously smooth muscle spasm, what are we thinking at that point? Asthma, what drug can we give? Yeah, you know, something that kind of go in there, hit all the beta receptors, you know, relax all that. The edema, CPAP, steroid. in case maybe nitroglycerin at that point. What about mucus accumulation?
Fluid?
What do you mean?
Well, I mean, if you, I think to moisturize them so they'll move. If you're getting like mucus plugs or something like that,
How are you going to do that?
like nebulize.
Yeah. Yeah, sometimes you might actually, especially if they already are intubated, sometimes it's actually you might have to dump a little bit of saline in there and just suction it back out, just again, decrease that viscosity. So, and again, obstructive lung disease at that point, a lot of times it's just we're looking at medication at that point, but we really cannot obviously reverse the process of what's already gone there. The thing is just trying to understand what kind of obstructive disease that we have and what are our limitations. Ventilation, continue here. Chest wall function, again, we kind of sit there and say, what's going on with the actual thoracic cavity here. And if something is broken, obviously, we're not going to be able to have good expansion. The other issues here, we got the hemos, pneumos, the emphymas, the pleural inflammation, and neurovascular disease. I think neurovascular disease are kind of thinking more of, it's an autoimmune, and it just went out of my mind.
Cystic fibrosis?
No, cystic fibrosis is actually, cystic fibrosis is all because your body cannot create one specific enzyme that kicks out chloride.
What about like cerebral palsy?
Huh?
Cerebral palsy, as far as neuromuscular disease?
Not for pulmonary. I'm trying to think of the one that actually eats up your receptors. I can't think. It just went out of my mind. Eats up your acetylcholine receptors. They'll come back to me probably about like later. But yeah, it's not fibromyalgia. What is it? If you're online, look at respiratory disease, acetylcholine degradation of
Is it where
acetylcholine.
like your
It's
sympathetic nervous system fails or something?
Is it muscular dystrophy? Muscular dystrophy is another actual degenerative neuromuscular disease. I can't think of the actual autoimmune of that one. It's driving me crazy. But the other ones here, neurological control is brainstem function.
That's like muscular overall, but like ALS, but that's like all muscles.
Yeah, that's all muscles. Yeah, that, like I said, they'll start breaking it down as well. So the thing is, when you got something like that, it's the chest wall is actually still intact. It's just again the neurotransmitter to get the muscles contract is the problem. So at that point, it's very easy for those kind of patients. You'll start ventilating them, and they don't want you to stop. Very, very easily. Brain dysfunction. Obviously, what we worry about there is some kind of head injury. Something that gets into the pons medulla. Phrenic nerve or spinal nerve dysfunction. Again, like talk about your phrenic nerve. Where's that at?
Cranium.
Phrenic? No.
Oh, no, that's
Somewhere
here.
back here.
Yeah.
Nine.
Yeah, 3, 4, 5. You guys remember that? 3, 4, 5. Keep the diaphragm alive. Yeah. So just depending on how bad, high up in the actual nerve damage is at that point. So.
Were you talking about myasthenia gravis?
Think-
Because myasthenia gravis that affects the use of muscle.
Yeah. That is. That's it. But for some reason, fibromyalgia kept going into my mind. I was like, I know that's not it. That's different. But yeah, myasthenia gravis. So diffusion issues. Make sure I didn't jump too far. Basically, what they call inadequate fraction-inspired oxygen. And that, again, like I said, for whatever reason, why are we not getting enough oxygen in? Obviously, we're kind of geared up to deal with about 21% oxygen in the atmosphere. But if we're not able to get that much down below, why are we not doing that? And obviously, we got our different, alveolar diseases here. And again, like I said, whatever can compromise or disfigure the alveolar beds, obviously, we start reducing surface area. Again, lungs ideally have, 40 square meters of actual surface area. So the more damage you do to it over time or disease process comes, we start actually losing that. And like I said, we're not going to have as much adequate diffusion at that point. So capillary beds, you can see it also can also be a victim of atherosclerosis. Again, we plug things up. We don't allow blood to go through. Because, I mean, ideally, when we get down to the alveolar level and we're actually moving blood, actually, remember those capillaries are only about 1 cell thick. So it's not going to take much to, start breaking up that circuitry in there. Interstitial space disease, high pressure pulmonary edema or high permeability pulmonary edema. Again, like I said, if it's that point, we've actually got more fluid coming in, and fluid's going to, can't obstruct or take a longer time for the, CO2, O2 to diffuse at that point. It's just got, more of a tough place to travel through. So perfusion, inadequate blood volume or, hemoglobin, or for, again, actually, if you want to get into some cases, you may not have completely functioning hemoglobin, which is, again, that's more of a genetic disposition at that point. Or we have some kind of impaired blood flow. Again, like I said, if we have a pulmonary embolus, we stop blood flow going through the lungs, we don't get reoxygenated. That blood's just going to kind of sit there back up and cause other problems along the way. So, and again, capillary wall, again, like I said, lungs can contuse too. So we get a good lung injury or chest injury, you got to sit there and remember, it's like all that energy traveled inward, what did it do at that point? How much damage? Because if it causes a lot of damage, we can see out here, what did it transfer back there? I mean, even if something is as small as a bullet, like I said, that cavitation could come in and rupture all that in the process. So risk factors, you're intrinsic, ones you're born with, again, genetic. Asthma, some people actually do COPD. Obviously, cancer is another one. Kind of interesting thing about cancer, cancer is 100% genetic, by the way. So have you ever heard that? I don't know if I told you. Yeah, cancer is 100% genetic. 20% you're going to get just because that's what your genetic disposition is. The other 80% is that you need an environmental stimuli to cause it. And that's obviously you get cancer at that point. But cardiovascular pathologies, I mean, obviously here we got a pulmonary edema. Again, we got a bad heart at that point. Again, we're not being able to pump blood out. We don't have a good ejection fraction. We're starting to back up, and obviously we start, flooding our lungs. Pulmonary emboli, again, like I said, usually if you do get a good pulmonary embolus, a good one will probably kill them right then and there. So, but otherwise, kind of the same concept. We necessarily get that VQ mismatch. Blood's not making it to where it's supposed to be, doesn't get oxygenated, everything falls apart. And of course we got stress. If stress can do anything good, it's for a very, very temporary basis, not for a long term. Too much cortisol and all that business, it will run you down. So extrinsic, things again more of external, the things you can control here, relatively control smoking. Obviously smoking causes issues of, usually big ones we run to see with smoking is emphysema, then usually kind of right after that you start seeing chronic bronchitis and so forth. And worst case scenario, you start getting the different types of lung carcinomas, which in all retrospect compared to most cancers is actually very high survivability rate. So, and of course, and if you have any other diseases, smoking can actually aggravate those and make it worse as well. Other environmental factors, can increase your COPD, irritate your asthma, and just so forth. You got to remember, you get these guys that have lung disease and they start having lung problems. They're already behind the curve as it is. Okay, and even if when we start talking more about kids, because you'll see one of these kids that have asthma and stuff, when they get pneumonia, like I said, everything wants to already swell up and constrict as it is. Then they actually have a disease process that's adding on top of that, and then you just got all that goo and stuff that's just sitting in there. So, like I said, it takes a lot away at that point. Obviously, you get somebody who's really old, like I said, COPD, and then all of a sudden, they're, obviously they're not. I think I ever told you this. By the time you're 20, you only have. By the time you're 80, you only have 40% of the lung capacity you did at 20. So you've lost so much by that. Okay, so obviously we start adding a disease process on that, then we get you sick. We're just dropping you down. Like, so you don't have the mechanisms you do when you're young to kind of cough and be able to have that organ reserve to kind of bear through it at that point. Actually, I got a second here. I'll show you something. Kind of a way to actually also look at some of these diseases. The big thing about this is usually people say this looks like a nice big bird or something like that. I've heard people comment on that. Emphysema, chronic bronchitis, and asthma. Understand these all are going to overlap at some point in the individual. Just because they might primarily have emphysema, they're going to have a little bit of chronic bronchitis and have a little bit of asthma issues and so forth. Versus the asthma here, they can kind of touch a little bit on both sides on that way. Does that make sense? See how this chart works? Just one of those things to kind of keep in mind. So when you kind of run into these guys, you got to remember they're going to have a little bit of the other issues on top of it as well. So ideally, we're looking at about 10,000 liters of air that's filtered, warm, humidified daily. And again, it gets diffused in the blood, and CO2 goes out. Again, that whole diffusion gradient going on there. And big thing here is I'd probably keep an eye on this. But understanding how the respiratory drive works. First thing, obviously, we have to have an intact respiratory, intact brainstem. We have is it a dorsal respiratory? Our dorsal, we have one that's dorsal, we have one that's ventral, and it's like one that's dorsal is all your rhythmic versus the one that's ventral is the actual ones that you can actually override. So, but ideally, most of the time, we just sit there and say usually it's in the pons or medulla at that point. But just kind of understand you actually got two things that are actually going in your brain. It says, I'm going to do the rhythmic breathing you do right now, keep you going on, and then when you need to take a deep breath when you run, we actually have another system that'll come in and override that. But all that has to be intact, so we can send that message down to the phrenic nerve, get the diaphragm to contract, chest expand, and so forth. So you got to have intact pathways, again, between brainstem and muscle. And muscles of respirations. And the big thing here is it's not just necessarily the neurological system, but we got to have the end motor plates to actually release the acetylcholine and have transmit onto to create that actual contraction. So patent up and low airways. Again, hopefully something that's free of obstruction or as minimal obstruction as we can have. Non-collapsed alveoli. If we have too much collapsed alveoli, what's that called? So, and of course, intact chest wall, pleura, and diaphragm. Like I said, we have the actual mechanical part, so this has to be intact and working in unison. So diffusion requires, again, we have to have non-thickened alveolar walls. And like I said, the alveolar capillary beds at that point are only like one red cell, blood cell thick, so they're just traveling right along, to that alveolar bed and just off and on loading right there. So minimal interstitial space without additional fluid. We're always going to have a little bit of fluid. In fact, do you guys remember your two, what are the two cells in the lungs?
Epithelial and, is that what you're talking about? Like,
There's two types.
epithelial, lines.
That's muscle. Alveolar 1 and alveolar 2 cells. The big thing here is, remember, is alveolar 2 cells. You're never going to be free of fluid because the alveolar 2 cells actually create surfactant. Surfactant reduces the surface tension so we can have that diffusion. Surfactant is basically our equivalent. It's soap. Yeah, it's soap. So if you ever get, we used to do the, crike, you guys ever done the crike or cut the animal tracheas from the butcher store? That was like a big thing a long time ago. It's really messy and nasty, to be honest with you, but sometimes you get a piece of lung and you can squeeze that piece of lung, and you'd watch all the surfactant drip out. So, but you need that relative moisture in there to reduce that surface area. So, and again, like I said, non-thickened capillary beds at that point. Obviously, we got to have perfusion-wise, we got to have adequate blood volume. At that point. We've got to have something that's going to go round and round. We've got to have hemoglobin, and preferably hemoglobin that's not bound or defective at that point. Some hemoglobin, people have hemoglobin issues that, there are two types of hemoglobin. You have your alpha and beta, and some people only just have the alpha. And that kind of limits him right there. People with sickle cell only has that alpha at that point. You guys familiar with sickle cell? Yeah. Sickle cell, the interesting thing, it's sickle cell is actually, how many people know the history of sickle cell?
predominantly in like
African
black
Americans.
people.
Yeah. Actually protects you against malaria.
Yeah, it's weird. It was like every.
So was that like an evolution thing? Because honestly, because where malaria kind of originated area, like
Well,
the body-
yeah, they call it an evolutionary, evolution thing. But the thing is, I always kind of find it ironic about evolution. They always say it's always by chance, and by chance, whatever is able to adapt and survive that environment lives. Well, something was smart enough to sit there and say, well, maybe if we take this away, we can resist this, malaria bug and keep living. So, but yeah, it actually, even talking about this with sickle cell, the biggest problem you're going to run into sickle cell is that they clump, and they'll aggregate, and they'll go into a sickle cell crisis, and at that point, but they'll be in hideous pain. They'll be just dropping a lot of pain meds at that point because they got to get those cells to break up and start moving again.
Doesn't it hurt you when it passes through?
Yeah.
I thought with the sickle, when it passes up through the capillary or something,
Yeah.
that's what caused the pain.
It's like
They bunch up.
accurately shapen
Yeah.
cell, isn't
Yeah, they're all like crescent moon shaped.
it? Yeah.
Versus a biconcave disc that's nice and flexible. These things go in and they'll get all jammed up together. So, and again, that can actually, again, screw up your perfusion right there too, because, like I said, if everything's kind of plugged up, we're not onloading and offloading, and like I said, it's not a very adequate means of oxygen transportation at that point. So, and of course, the big thing here, functioning left heart. We need a left heart to pump systemically. So control ventilations. Okay. Okay, big thing here is the CSF fluid. They say is pH largely influenced by CO2. Why do you think that is?
Like CSF is in spinal, like cerebral spinal fluid? For vasoconstriction and dilation.
Yeah,
The whole thing like hyperventilation,
That's
like
what I'm thinking.
vasoconstriction.
you're close. Actually, the big trick here is CO2 cannot diffuse into the actual spinal column at all. We've got, I think the actual blood-brain barrier actually can keep it out. It's too big of a molecule. Do you guys remember your buffer system at all? Remember how that equation worked? We got hydrogen plus carbonic acid. We got, no, it's not, it's hydrogen plus bicarbonate, carbonic acid, then breaks to water and CO2. Well, remember I was telling you it's always sliding. You guys didn't. I didn't go over that. That was Clark, wasn't it? Yeah, it slides back and forth all the time. Well, the problem is that when that CO2 is starting to build up, they'll say, well, if I can't go out the CO2, I'm going to slide and go back the other way. That free hydrogen can pass through, and then that can get into the CSF fluid. And it's like, oh, wait a minute, pH is dropping here. We got to get rid of this stuff somehow. So that's another way it'll actually start going and say, okay, breathe faster, harder, kick this stuff out.
So that leads like encephalopathy or something like that?
Um,
Probably gets to it. Acidotic.
It could be a really bad day. So obviously, our increased PaCO2. We got our chemoreceptors, baroreceptors, stuff like that going on. The whole chemoreceptors with COPD. Again, it's when they always say the hypoxic drive. Understand this really truly is a very small population. And everybody, I know they kind of teach you from all the way from EMT school, be careful about giving oxygen to a COPDer. It's really, you really would have to like flood them for a while to really see it make a difference. I mean, really, really work at it. But chances are if the COPDer is, losing its respiratory drive, it's probably because of something else, not probably because of the oxygen. So just understand it's there, but I mean, you really got to be hammering it with oxygen for a long time to kind of see that effect go. In fact, there's actually some people out there that will actually argue and say there actually is no hypoxic drive at all. So again, stuff you might want to keep an eye out for. Medulla initiates ventilation, phrenic nerve innervates the diaphragm, spinal nerve innervates the intercostal spaces, hearing reflex prevents overinflation. Okay, nice way of saying this. Okay. Basically, the medulla gets this impulse and says, okay, you need to breathe because I'm tired of all this hydrogen around me, right? I'm sick of this crap. Okay, sends the impulse down the phrenic nerve. Phrenic nerve goes down to the actual intercostal spaces and diaphragm. Diaphragm says, okay, contract, expand. And what happens inside the lungs? What's the pressure change?
it increases or decreases.
Decreases. So we bring air in, right? Bring air in, and then when we relax, what happens? We increase pressure, kick it out. Okay. The herring brewer reflex, believe it or not, was only proven in dogs. There's nothing in humans to actually quantify that at all. But the idea was that it was something there that would prevent the overinflation of lungs. So I actually had a physiology teacher. She was telling me when her very elusive and very curious late night stories in lab. They said one time, keep in mind this is a child of the 60s, by the way. So they had this big old, they got like one of those cardboard rolls you have like with the paper towels on. They put it up onto a horse's lung, and they said they kept blowing, and they kept going and going, and it just stretched and stretched. This was a horse's lung that they pulled out,
So the horse's lung doesn't have a stretch receptor?
Well, this was a lung that they pulled out. The receptor is only proven in dogs.
Okay.
It says
So it's a theory.
it's a theory. It's
scientific proof.
It's just the whole, like, the air pressure inside and
Yeah,
outside have even, so you're going to stop. It's not.
Well, it's
unnecessary.
What I'm saying is you take a deep breath, like, once those pressures,
Yeah.
air's going to stop coming in.
Once
Yeah.
physics
How
takes
would you
over, it's
control
kind of.
your-
yeah.
Why
And
do you need a stretch receptor?
Well, the thing is, you're limited to what this can expand to anyway.
Yeah.
I mean, for whatever reason, yeah. And unless somebody decided to do some kind of alterations, let's say we can, make your lungs, chest expand out to here. I mean, never say never, but yeah, just understand it's this concept. The stretch receptor says, hey, stop for overinflation, but real life, like I said, only proven in dogs. So respiratory assessment. So, do you think this might be important?
Yes,
Yeah.
always.
Yeah. Okay. So here's a little story. Get called in the middle of the night to a ghetto hotel, right? You go walking up there, for somebody's sick. Fire department comes walking out. They're kind of, all mad and irritated. This is a Colorado story, by the way. They're irritated that, huh? Oh, yeah. Well, they're coming out. They're all irritated. Like, yeah, this guy, he's just, he says he had a problem breathing. He said he was coughing up blood. And me and my partner go, we're like backing up already. Like, what do you mean coughing up blood? I don't know what his deal is. I think he's a smoker. And we're looking at him like, was this only tonight? Yeah. Are you only coughing this stuff up at night? Yeah. You have any fever, chills, sweats? Yeah. We're like,
It's like, okay.
we're lost on it. But, we're like backing up, and the fire guy's like, what's wrong? Got frickin' tuberculosis. So, yeah, that's, and by the way, have you ever heard tuberculosis lungs?
The what?
TB lungs? Yeah, have you ever heard of mariachi? Not mariachi, maracas, yeah. That's what tuberculosis lungs sound like. You guys know how that, I don't know if I think we go into tuberculosis, but you understand how it makes it actually makes a little tubercle and actually forms a shell around it. It's a nasty little booger. But anyways, so yes, please protect yourself against situations like that. Or in case you just don't want to catch the general pneumonia that's going around. But anyway, again, other issues you got to look for, seen safety-wise, is this could be an airborne hazard. If you see a bunch of people coming out of a mall and they're all coughing and hacking and snotting and stuff like that, I'd probably be thinking there's, throwing up, vomiting, seizures. That's usually a bad sign, by the way. Don't go in the mall. Stay outside the mall. Yeah. Yeah, you see a big, spray paint that says V and then X. That'll be your giveaway. No, it'll be more than that. But yeah, just be careful, stuff like that. Or in my case, I ran into a cloud of hydrofluoric acid. Yeah, so it was bright, big, and orange, and we didn't even know. We walked right into it. That's hydrofluoric acid. Everybody's running this way. Oh, time to get out, huh? And of course, number of patients. How many patients are you treating? And again, how severe are one or the other? Do we need specialized equipment? Especially if we start to get something that's mass casualty of people having breathing. A couple things you got to look out. Actually, seasonal things you got to look out for, especially is CO2. People love to crank up their heaters over the holidays, and especially the elderly. They really will crank those things up hot till it feels like it's outside right now, but they may not have a functioning CO2 detector. Next thing you know, everybody up there is getting, nauseated or throwing up, or they're passing out and they don't understand what's going on. And Like I said, at that point, obviously get them outside and give them some oxygen. But other things you got to work for, like I said, it's just, is there like that hydrofluoric acid issue? Do we need hazmat at that point? What do we need to do to take care of problem A? Because we're probably taking care of problem B, which is the patient right now. So, and again, is the environment creating things worse or better for the patient? Depends. Identify potential life threats. Please tell me you can do this now or live very well, one of the two. So initiate appropriate therapies. Obviously, the first giveaway is just give them oxygen, right? When I give them high flow oxygen, can't go wrong at that point. The thing at that point is, again, like, so obviously it's, obviously we get the ABCs, figure out what our assessment is. What are we dealing with? I mean, obviously if they're unconscious, that's a whole different issue. But assessment-wise, you really got, again, start learning to dig really, really deep. Listen to your lung sounds. Try to get them to cough, say vowel sounds while you're listening to their chest and so forth. And, so try and get, like I said, was there a history behind it? Is there not history? Is there a comorbidity that's going along with this that's making this worse? And then we can kind of figure out, what's the problem here? Is it ventilation, diffusion, perfusion, combination of, whatever the case may be. So airway, listen, talk to the patient. I'm not a very, you guys know I'm not a very big fan of putting my, ear to someone's mouth. I don't recommend it. So again, noisy breathing. Again, like how is it noising? Usually if we hear it, it's usually, some kind of, usual obstruction at that point. I mean, worst case scenario here, wheezing. If you hear wheezing from a patient talking to you or trying to talk to you, it's usually a very, very bad, very bad sign, late sign of asthma. So snoring, obviously we got the tongue blocking in the way, stridor, partial airway obstruction. And gurgling, that's kind of self-explanatory, I'd hope. So is the patient moving air? Come on back. If they're moving it adequately, is oxygenating the blood? Again, it's the best way to think about it is right depth and effort. How fast are they going? How deep is it going? How much work are they putting into it? Like everybody here is not putting in a whole lot of right depth and effort right now. Now, sure, come test time, I'll probably see a little bit more out of you guys at that point. So, the thing here, keep it simple. Make sure when you watch them breathe, is everything expanding correctly? If when in doubt, you can always put their hands on their chest, on the sides of their ribs, breathe. Is everything expanding correctly? Are there signs for increased respiratory effort? What would be my signs for increased respiratory effort? Tripoding, flaring. Why pursed lips, by the way?
Treating positive pressure.
Accessory.
Yeah. So skin color changes, usually kind of your late sign. Problem is with people with real bad COPD or cancer patients, secondary smoking, their skin usually looks pretty ratty to begin with. And a lot of it, believe it or not, the carcinoma in the lungs will actually causes dehydration. That's one of the reasons they'll have that real dry look to them. So listen for air movement to nose and mouth from a distance. Listen to their lungs. Oh, please listen to lung sounds on all your patients. You'll be surprised what you'll find. Like I remember one time we thought this guy was having seizures because he was febrile, and turns out I listened to his lungs and they were just full of gunk and crap and everything else. It's like, well, maybe that hypoxia could cause it too. Go figure, right? So movement, air, nose and mouth. Again, more symmetry. So what's orthopnea? Okay, what's P&D?
Free waist in the middle of the night has difficulty breathing.
What's the difference between the two? Why? What's P&D usually a result of?
CHF.
Yeah. So, yeah, just remember that orthopnea, for whatever reason, if they, they can't sit down, they can't keep, they have to keep that self straight up. I've seen real bad asthmatics, they'll do this to the wall because they don't want to crunch down. They're trying to get everything they can at that point. So nasal flaring, tracheal tugging, retractions, again, accessory muscle use, et cetera, et cetera. Adults or children, it's always a bad sign. And, of course, cyanosis. If you're seeing cyanosis, you're probably seeing it too late. So, of course, oxygen immediately. So, all things you got to keep in mind here. And again, for breathing, it's altered mental status, shock, hemorrhage, chest pain, trauma, so forth. Now, this is going to get kind of tricky because sometimes your book says different, and between what your actual respirations, which is too low, too high. The only thing I've ever seen them really agree with, if it's below 10, it's too low. And, when I went through, is if the respirations are above 30, it's,
We're forcing really low.
yeah.
Because if you're exercising, your respiration's
Yeah, it just, it's
It's almost on an individual. If people like breathe 8 times a minute and they do fine, I mean,
it's going to be very relative. Again, it's rate, taking that whole picture of rate, depth, and effort. If somebody's sitting there breathing really slow and shallow, and they're completely oriented, is that a bad thing? Yeah, leave it alone, right? Yeah, never screw up a good thing. So, yeah, the big thing is, like I said, I know, and you're reading into your book, and especially people run into this as scenario questions, because they'll see, like, well, what are the magic numbers, kind of a thing. Everybody in a book, I don't know, I forgot what your book put. I don't think it was this, but
test-wise, you go this or book?
the test should be pretty.
Respiration is 6.
Clear?
Yeah, it really should be something like that. Respiration. It's kind of like really that greater than 30, less than 10,
Okay.
and it should show up, and they'll be like, patient's breathing about 38 times a minute, gasping for air, speaking 1 to 2 words. It's like, there's a problem there. Sign refusal, go to triage, get out of here. But just remember, it's the rate, depth, and effort. And again, it's going to be relative on how healthy they are, what's going on with them, and so forth, or what kind of disease process they have. Meditation, again, good thing to look at. How are they meditating or not meditating at that point? Trauma, again, any kind of trauma, we got to sit there and say, well, whatever damage is out inside, how far did it go inside? And the only thing we're going to do is look, listen, and feel as best we can at that point. So, and otherwise, they sit there and say, if you think about giving oxygen, you probably ought to give it. And if you do decide to give it, you should give lots of it. That's actually kind of suspect because a lot of people are going into this thing of, whole argument of free radicals. I don't know if you guys have been hearing a lot about that, but it's something I'll say, said before. It's right tool, right job. It's something somebody's having a little difficulty breathing, secondary to pneumonia. They're coughing up something, but they're speaking full sentences. Color's decent, pressure's good. I think a nasal cannula is pretty appropriate at that point. We don't need to be throwing a mask on everybody. Get the whole picture. That's what we got a lot of those toys for and a lot of our assessment. And say, what does this person really need? So if you're thinking about bagging a patient, you probably should be. Or, probably preparing intubation equipment maybe at that point. So just remember, oxygenate. What's the difference between oxygenation and ventilation?
ventilation, mechanical,
Yeah.
gas exchange.
Yeah, the actual gas exchange itself. So, but understand that to say here again, need to ventilate is not the same as need to intubate. Again, we're trying to break a very innovation-happy culture. I mean, something you guys haven't really had to deal with. But have you guys run into that in the field at all? You guys are just happy innovators?
I think our culture is the opposite. I think all of our mates are scared of innovation.
Oh no! I mean, like, so that was just. No, that was just like, again, that was a standard for us. First chance we got to throw a tube in, we were there. If we could push you out of the way, even better.
You didn't know what the day is he's altered.
Right.
Yeah, he's getting a nasal tube. He'll be. Watch this. Did I ever tell you I saw a guy stand up, take a nasal tube? I did.
There's a video on YouTube about it's
He took a
anesthesiologist.
He intubated himself and
Yeah.
he cried himself. Or needle cried.
No, he used needle crack to lidocaine to
Yeah.
numb his throat, and then he intubated himself with one of the kaleidoscope things so students could watch him. I'm thinking we should do that just so we can see.
No. I'll do it on you. I mean. No, I saw this guy real bad COPD, and he was doing the whole. I mean, he was literally doing this, standing up to breathe and stuff. And I remember a guy I was working with. He was like, "Okay, you can put this in your nose." I mean, the guy didn't flinch or anything. Just stuck a nasal tube right in there. It was pretty impressive. It was really impressive to watch.
squeeze this every 5-6 seconds. Sorry.
He probably
You better be careful. Things like that have happened. So, aortic or circulation. How are we going to tell the heart's beating?
listen, feel, and check a pulse.
Yeah. Oh yeah, just see what's on the EKG, right? But again, external hemorrhages, patient perfusing, again, for what are they, again, if there's a circulation issue, what's the problem? Are they a couple quarts low? Is there something wrong with the actual plumbing itself, or is there something wrong with the pump? Simple stuff there. But yeah, don't let respiratory failure distract from your system of circulatory. They go hand in hand. Those two will always go hand in hand. So disability, again, brain's very, very sensitive if it doesn't have oxygen or sugar. So again, look at stuff like that. When the patient stops fighting, doesn't necessarily, he's not getting better. Well, he might be getting better for you. I will say that much. At least, but the only thing, have you guys ever problem with the CO2 poisonings? If they aren't semi-conscious, if you bring them back, don't be surprised if they come back fighting. Just a little FYI for you. I learned that one the hard way. Guy locked himself in the garage, all this other business, and gave him some oxygen, come out there, and he came out, and as he was coming back up, then gave more oxygen. He was like, "Oh God, I'm so sorry." And I'm like, "Come on, man." Come on. So again, signs of life-threatening, pulmonary problems. Altered mental status is the big one, the very, very big one. You shouldn't be seeing changes in that. Absence to decrease ventilation. If they're starting to get slower and slower, they're it's usually not a good sign. Some people just breathe very shallow to begin with. It's just when you're kind of watching that, they're not talking as much, they're not breathing as much, they're kind of getting a little listless on you. Audible stridor and wheezing, very, very bad sign. If they speak in 1 to 2 word sentences, that's a very, very bad sign. We're very late in the game. Just remember that we should be able to speak. Generally, people should be able to answer things in full sentences. You start hearing deviations of that. That should be a little flag to you to kind of start watching and look closely. Sustained tachycardia. Again, like Samara told you, tachycardia is usually a reflection of something else. So again, if you're getting hypoxic for whatever reason, one of the things your body will do is try to compensate by kicking the heart rate up. And of course, we get that pallor diaphoresis, we're getting that cholamine dump. And then, of course, we got the obvious muscle retractions and accessory muscle uses. So anyway, chief complaint, dyspnea, subjective, sensation of difficulty breathing. It's uncomfortable. You can also get chest pain, cough, hemoptysis. What else do you think could be difficulty, pulmonary complaints or respiratory complaints?
Lightheadedness.
Could. Do I have pain when I breathe in or breathe out? That's something I keep in mind. Does it hurt on the side of my chest when I breathe in? That's usually a good one for me. Pleural rubs are kind of like take a deep breath, but God, it always hurts right here. Things like that. I keep trying to I feel like I can't get a deep breath. It's all those kind of things you kind of want to kind of pick apart, like, well, tell me, what does it feel like? What has it happened? What changed about it? So, associated symptoms, like I said, if we can kind of figure out what exactly, or it could be from what the patient's telling us with their respiratory issue, we start looking for something that might be associated to it. Obviously fever, chills, we're looking at some kind of infection. Sputum production, that can be quite a few things at that point. And bite and fatigue. Fatigue can bring a lot of things here. It could be infection, it could be hypoxia, and so forth. So how long has your difficulty breathing been? Fast or slow? Anything make it better? Can you cough? Are you coughing? Is it productive? Was the sputum look like, smell like? Pain? What does the pain feel like? So if you kind of notice you answer one question, that question leads to the next question, it leads to the next question, and so forth. So generally, though, when you actually, getting to cough up stuff, some people, I don't know, they always sit there and say, yeah, can you spit or can you cough so I can see what it looks like? Usually I'll just ask them, say, is it yellow or brown or anything? No.
Smell it, please.
I won't do that.
No.
I've seen people do some of the strangest stuff, like, no, 'cause sometimes they'll cough and they're like, here, spit into this, and I'll just throw it away. And some people are like, oh, let me. Nah. Coughing up blood. Coughing up blood, by the way, is just generally a bad thing. But I will say this much: if somebody's got really bad bronchitis and pneumonia, and they've been coughing up for a while, you actually can rupture vessels, and they actually get a good, spat of blood coming out. A lot of times, what happens is people will freak out because they'll see a little tinge of blood. But like I said, you can rupture, the little small vessels on the way up because of the forceful cough. But it's when they're coughing up, lots of blood. It's pretty indistinguishable, So. But they say yellow or gray is more of an allergic or inflammatory response. Pink frothy, obviously we know that one. So previous similar episodes, has this happened before? How bad did it get? Did they have to tube you? Actually, a really good question is, sometimes I ask people having real difficulty breathing, is, are you getting tired to breathe? I've yet to find anybody, I never had anybody ever lie on or try to fool me on that one, because they'll be like, and that's like, okay, I'm going to get this little piece of equipment out, and that out, because you're probably not going to be breathing much longer. So diagnosis-wise, again, what do they have? Do they have CHF and emphysema? That happens. Throw a little diabetes on top of it, renal failure. We got a good time. Intubations, big thing with intubations, hospitalizations, at least it gives you an idea of how bad can get. It's like, yeah, last time I had this problem, I got intubated. And you're like, okay. So I guess we could be going down. And again, any aggravating factors. Is it seasonal, or were they in a smoky environment, or whatever the case may be. So other things consider, again, more comorbidities, previous heart attacks, do they have any, or hypertension, do they get any CHF issues from that? Do they have any COPD, asthma, surgery stuff? Again, just dig and see, is anything that you're telling me could compound what you're dealing with right now or be creating the problem? So, medications, I guess big ones here. We got the sympathomimetics. Albuterol is the big one. I think we're going to go into them here in a minute. I think we go more into them in the other slideshow. But yeah, steroids, mast stabilizers, leukotriene agonists, and by the way, this is a nice way of saying high dose caffeine. That's really what that is. Cardiovascular-wise, obviously diuretics, cardioglucosides, digoxin. Yeah, pretty much. Just a quality of life drug, that's all. So, of course, vital signs, again, rate, depth, regularity. Again, unusual respiratory patterns, again, Kussmaul. People, they're just breathing hard because they're just trying to offload the CO2. At that point, like I said, do you know only 50% of people can smell ketones, by the way? Only 50% can actually smell ketoacidosis. Yeah, that's, again, little interesting little genetic things there. Remember what Shane Stokes is? Yeah, light, harder, light, harder, so forth. Breathing, yeah. And of course, central nervic hyperventilation. Hard, fast, pushing it out, stuff. Other things look forward, again, tripoding, legs in a dependent position, or are they standing up trying to do that, trying to open up everything they possibly could. And again, children, might actually see more of the abdominal seesaw than you actually probably will with adults. But you will see it. In fact, if anything, you'll see the adults just kind of really push in to try and push air out, if anything. But nasal flaring, pursed lips, so forth. The neck, tracheal deviation, tugging is probably a big one here. Is there any, this was a sternocleidomastoid. Yeah, does that look like a very thick muscle? Again, accessory muscle that just kind of build up. Sub-Q air, again, bad thing at that point. Because, by the way, just so you know, sometimes sub-Q air doesn't always necessarily mean pneumo or an actual pop of the lung. You can actually get tracheal tears, and that can actually cause a lot of sub-Q air. And that, which kind of sucks because the only way you can actually plug them, if it's actually trach, you can stick a tube. But just one of those things to keep in mind when we start looking at trauma around the neck. But that's more like a Mallory Weiss, Mallory Weiss syndrome kind of a thing. No, it's dysosseous varices rupturing and stuff like that. I'm talking the actual tear in the trachea, and that's what's actually causing the leak of air. It can actually cause a whole pneumo thing, but you don't have to pop a lung. You still have lungs that are kind of bouncing against it. So, chest-wise, barrel chest. You guys ever seen a good barrel chest? Yeah, just remember the barrel chest. We're here. We're relatively flat, so we can actually expand. They've lost that. So again, they got to kind of compensate for that as well. Flail segment, paradoxal movement, pretty self-explanatory. Breath sounds, and we'll take a break from here.
It's like a massaging chair. Could you move it like this?
Okay, moving forward. Chest and things else to look forward to. Third heart sound. Obviously, we're looking at kind of a CHF issue at that point. Tenderness, instability. Again, looking at more trauma. Sub-Q air, we talked about that again. Fremitus, that's just nice. Palpable vibration. That's a nice way of saying that. Some assessment-wise, they'll have you sit there and say E, you'll feel the vibration going down their back if you want to get that in depth. Symmetry, we've talked about that. Again, looking for peripheral cyanosis, edema. You guys remember what clubbing is? What causes it?
Smoking.
Yeah, smoking, buildup of CO2. Carpal pedal spasms.
From hyperventilation.
Yeah, problem is you hyperventilate. You depolarize faster. Your muscles will depolarize faster, and that's all. So again, more adventitious breath sounds, snoring, stridor. Talked about that. Rhonchi, the rattling in the larger airways. Generally mucus. Usually the fluid will be more in the smaller airways, and you'll get that nice little bubbly sound that goes with it, crackling sound, or just rubbing hair. If you got hair long enough, you can rub it against. Sounds the same. Wheezing. Wheezing is pretty straightforward. The only thing you'll kind of find something kind of different is you'll get people that sound very shut down. You'll start giving albuterol, and then they'll go to wheezing, and then they'll open up and clear. So just be kind of careful on that one, because some people it just works backwards. Wheezes can be inspiratory and expiratory, primarily expiratory. Usually the air getting in is not the problem, it's just the air getting out. So cough. Again, like I said, we're usually trying to force something out at that point. So at work, again, why are you coughing? Is there a place, time, cause, position, productive, non-productive? Sneeze, clearing the nasal passageways, mucosal irritation, or if you want, you can go, that off chance you get bored, you can always stare at the sun and I'll make you sneeze. I don't know if you guys have ever done that. Yeah, that light will actually cause something like that reflex.
No, seriously,
Yeah.
it works.
So size, the only thing is size is it just prevents atelectasis. That's the only reason why you take those, deep sighs. Usually it's not always secondary to boredom, even though that's what a lot of people think. You must be bored, you're not paying attention. No, you're trying to keep your lungs open. You're not moving around. So hiccups, they still don't know what purpose, why we even hiccup, but some people can actually have neurological defects and they go into hiccups for like 3 days.
20 years.
Yeah. Again, looking at other causes, modified breathing, pancreatitis, hepatitis, like I said, you're building up actually kind of a toxin, can get a little acidotic. Same thing with cancer, like I said, you're screwing up all your enzymes at that point. Pneumonia, pretty self-explanatory. So, hiccough, usually corrected by a hiccup, holding breath. We don't usually do the paper bag thing, just to let you know. Even if they're hyperventilating, don't do the paper bag thing. Realistically, either calm them down, give them some gum, snow them out, or let them pass out. There's actually been more problems with doing the rebreathing than anything else. And you guys remember Valsalvas. So, tell me about a pulse ox. What exactly does a pulse ox read? Yeah. It's near red and infrared rays. That's all it is. It says goes back when it says, is there something bound? Hey, great. That's it. So if you have anemia, do you think you could have, what do you think your saturations could be?
Could be 100%.
Yeah, be 100%. You still don't have enough blood cells.
Like sickle cell, will it show 100%?
It's only going to show, the only thing it says is there hemoglobin? Is there something bound to the hemoglobin? So if it sees something bound to the hemoglobin, It's happy.
And that's the percentage.
Even
yeah.
if it's only like half of the hemoglobin?
It doesn't see half of a hemoglobin. It says, is it present?
There's something there, there's something.
I see X amount of hemoglobins. I see this many. Something's bound to it. Yeah, carbon monoxide will bind all over the place.
What's that illness where you have more than average hemoglobin? So like you could have a low O2 stat, but you have enough bound hemoglobin that's in your normal.
I have no idea.
I can't remember what it's called, but you have more than the normal
Wouldn't that be a
hemoglobin.
good thing?
So you could be reading like 80%, but you have enough bound.
I've never heard of that.
It's in our textbook.
Well, peak flow meters, we really don't use those. You actually see them more in clinics. And that's also have a little butterfly thing you take in, going red to green. It says how much your expiratory volume is at that point. Sometimes patients have them, sometimes they don't. Capnometry, again, actually we get a qualitative and quantitative assessment reading at that point. And again, we're seeing what is actually coming out and how much is coming out and how often. So again, causes of elevated CO2, fever, shivering, exertion, drugs, huh?
Metabolic drugs.
Yeah, just whatever's going to keep. Really anything that can keep the CO2 in. That's all it is. What can cause create CO2 and keep it in, or both. So, and of course, the flip side would be hyperventilation, or we're not turning oxygen into CO2, and thus we're dead. That cannot cause a big decrease in CO2.
Hypothermia.
It's slowed down. You can drop it, yeah. So,
I thought it caused decreased CO2 when you hyperventilate because you're not blowing enough off.
You're blowing too much
You're
off,
blowing
you're
too
not
much.
retaining as much.
Yeah, you're decreasing.
Your pH is decreased.
So since that's kind of like the prime work, like one of the respiratory drugs, one of the main ones, why don't
Which one?
the body like naturally slow down? The decreased PaCO2. Why doesn't their respiration just naturally slow down as that CO2 decreases?
It's kind of more of
They're like overriding the system
Yeah,
themselves?
they really are.
Or just-
They've-
It's psychological thing. Mainly you're physically overriding them.
well, they're not really physically doing it. It's just caught in a loop at that point. Because some of these guys, you'll see people that hyperventilate, and they know they're hyperventilating, and they're trying to stop it, but it's whipped in that cycle. And like I said, either one, you got to slow them down with some kind of drug, or like I said, I've seen a lot of cases, they'll just pass out, then they'll start slowly breathing again
Seems to me that almost
and reset themselves.
not proves, but is a reason to believe that the hypoxic drug exists. Because their O2 is going to be low as well as their PaCO2 if they're hyperventilating. 'Cause
Actually
they're not
goes
having
up.
time to, you're not having diffusion, like, you're not giving enough time. You see what I'm saying? Like, if you're hyperventilating, it's happening so fast, the diffusion's not happening, your oxygen should be decreasing as well.
I couldn't say for sure, because I'd be more on the side of you're just blowing, if you're breathing hard and fast, you're blowing a lot of that off, but you're still getting enough oxygen saturation, because usually those guys that hyperventilate, their saturations are going to be very high at that point. So, never say never, but. So, anyway, normal 8200 millimeters per mercury. Again, these are more blood labs at this point. So, decreased PO2, again, obviously we are fluid in the alveoli, we are not getting O2 into the system for whatever reason. It can be shunting, from a PE, it could be atelectasis. Again, like I said, O2 is not finding its way in. So if for whatever reason you actually do get labs, you see them less than 60, we're going hypoxia at that point. And that's not sustainable for life, really. So again, O2, ventilate if necessary, and that's it. Any questions? This is all going to be one giant integrity thing. Anybody care?
Nope.
Okay. Mechanical ventilation. This is something that's actually starting to pop out. In fact, if anything, your book talks about automatic transport ventilators. And those are usually more of a gas-powered machine. Some places actually have the regular portable ventilators at this point. Just kind of talk about this. The whole point, keep in mind when we ventilate somebody, we're actually causing positive pressure. When we breathe, we're creating negative pressure. Okay? So we actually have two different things, two different kind of pressures going on, but obviously we're trying to get the same end result. But again, like I said, we're looking at if we're having to ventilate somebody or putting on a ventilator, like I say, for whatever reason, they're not maintaining their own respiratory drive, or something's giving up or quitting, for the case of we have to do it for them. So again, we want to increase efficiency of breathing, increase oxygenation, improve ventilation, perfusion relationships. This can be kind of so-so because it's positive pressure ventilation, we can actually cause a little bit of decrease in preload. And so you got to be be careful with that. So decreased work of breathing. Again, if somebody's struggling to breathe, we kind of want to give them that extra punch to go with them. So you guys ever see the iron lung outside behind the ambulance? Yeah, actually, I don't know, it should be still there. We have an actual iron lung. We were actually supposed to go into the display case. It was going to be cleaned up in the display case, but it was too big. But yeah, these people would actually sit in these things, and it actually caused that negative pressure to the lung to expand. And they usually, hopefully, it was a temporary thing. But yeah, that was one way they could keep ventilation that way.
Is that the thing they put people with polio in?
Yeah. Put a lot of people in those things. So. But long-term ventilation, but again, like I said, it's negative, so it gets the normal intrathoracic hemodynamics. And again, but the problem is you're just sitting there, laying there all the time. That's it. Positive pressure, again, like I said, we're actually causing that pressure to go inward. And we actually need some kind of airway or adjunct to kind of be able to make that happen, whether it be a BBM, whether it be a King LT or tube, whatever our little monster of choice is. And usually we kind of break it down into pressure timed and volume cycled. Again, a lot of this slide show is getting very familiar with the terms. And because if you go to critical care, we'll talk a lot more about this. But it's just kind of getting an idea of okay, I can see how this kind of works, because realistically, all these little things we're going to talk about actually are like one big circle, and you got to play with them so they all work in sync. So pressure cycle. Basically, it says I'm going to put X amount of pressure into your lungs. That's all it's going to do. I am going to keep pushing until I get X amount of pressure. I may not push hard, I may not push fast into your lungs, but I'm going to get an X amount of pressure into your lungs. So, and again, it can change. It says here, it says changes with airway resistance, lung compliance, but we're going to achieve a certain pressure in there. That's all I'm worried about. Once I hit a pressure, then we'll stop. So. Use short term with patients with no pre-existing thoracic problems. The volume, now this is where we're going to kind of have a little bit of shift. Now I want to get X amount, how many liters of oxygen or air into your lungs at that point. And we were talking about if you remember way back, we were talking about how do you figure how many cc's per kilogram, was it 5 cc's per kilogram to figure out what their total volume should be at that point. That's kind of what we're playing with here. We want to make sure we get so much volume in there, okay? And this can be used for a couple, again, depending on the situation. Their lungs may, again, talking about cystic fibrosis, we might have to adjust that because they only be able to take maybe 400 cc's, while compared to somebody of their height and weight, they take about 500. So we want to make sure we get that max, volume inflation in there. This is different. You understand the difference between the volume versus the pressure? Okay. So, again, all the thing is we set the thing is to hit this volume. We just keep going until we hit this volume. Stop. We're done. So, but the thing is, we can obviously cause higher pressures with it. So, see the downside? See, like I said, a lot of these things are all going to be playing one to the next, and influence the other. So, cycled terminates inspiration at a present time. So, volume is determined by length of inspiration, preset limit, airway resistance, compliant. We're just going to have a big cycle of how this is going to work. To the next, to the next, to the next. Capiche? So, controlled mechanical ventilation. This is pretty much, we snow you out. We are breathing. We got the machine breathing for you. That's a nice way of putting it. So it's The only thing you have to worry about is with contraindications like a flailed chest, obviously, because we're going to have that mismatch of the actual thoracic structure going on there. Patient is incapable of initiating breaths. Like I said, you're snowed, we're breathing for you. You know, we're going to tell you how much you're going to breathe, how many times you're going to breathe, and that's really about it. So, assist mode, this is where it gets a little bit different. Let's say you're somebody who's had, I don't know, maybe you were that guy that ran into that cloud of hydrofluoric acid and you actually did have some problems, and we're actually trying to get your lungs a little bit healthier again and put you on assist mode. So I would start taking a breath, and that thing says, oh, wait a minute, you're taking a breath. Let's give him a little bit extra help to make sure he gets a little bit more volume in there, so we can get a full expansion, because maybe he doesn't have the strength or lung, right now to open all the way up. So we're going to kind of help him push in there.
So it's going to be on BiPAP?
BiPAP always has a continuous PEEP.
Okay.
This is following you. This is watching you. So when it senses you breathe, BiPAP just goes. So assist control, pretty much, like I said, patient breathes, take a deep breath, everything's fine, right? Well, let's say, for whatever reason you're breathing, all of a sudden, whatever, you quit. Machine says, you're not breathing, fine, I'm going to take a default rate, kind of like a pacemaker, really. I'm going to take a default rate and say, I'm going to start breathing for you. Then once I sense you breathing, okay, I'll help you, and then I'll back off again. That's all assist control does. So, intermittent mandatory ventilation, patient breathes on their own. Machine breathes at preset intervals, so it's going to go. Patient determines the tidal volume of spontaneous breath, so I'm going to take it in. Machine's like, okay, I'm going to help you, but once you stop, I'll stop. This is kind of, we start taking away. We're trying to get this person off the vent at that point. We're trying to sit there and say, we really want you to do this on your own. Is really what we're trying to do. We want to get you to do this off, But it's ideally, especially elderly people with real bad COPDers, once they get on a vent, they'll give up. They'll just want to live on that vent, so they got to start weaning them off slowly. Synchronized, it's just pretty much we're going to go along with your breathing again, kind of a thing. Okay, so machine times to delay ventilations until the end of spontaneous of patient's breath. So as long as we're going to kind of go, we're going to kind of go. Okay, no, now we're going to go. That's all it's kind of do. So you kind of see the difference here? Yeah, it's be familiar with the terms right now. This is one of those, really critical care class. We have like a whole day on this of just explaining how all this works. So the other thing here is you do need to be familiar with is PEEP, positive end expiratory pressure. Basically, this is this nice little air pressure that keeps everything inflated after we have exhaled. Okay, the machine does this too. Like Doug was talking about BiPAP. See, CPAP just blows in, keeps continuous PEEP. When you do BiPAP, it actually adjusts because it senses your breathing. But its big thing is we want to keep that PEEP open. We want to keep those airways open even when you're relaxing.
So BiPAP, the pressure gets lower when you're breathing out? So you're not breathing against as much pressure?
Yeah.
But it's still continuous pressure to keep it
Yeah.
open. It's
A
just
small amount of continuous pressure.
Yes.
Increases, decreases.
Yeah. The whole, like I said, we just want to keep the lungs open. Like I said, right now we normally have PEEP. We probably have about 5 to 10 centimeters of water, whatever they put it per PEEP. Some of these guys, when they're real bad ARDS and pulmonary, to the point where they're getting, or the cardiogenic shock, like I said, they're losing all that. They need that extra push to keep either one fluid back, or with ARDS actually have degradation of the actual lung tissue itself. Like I said, it's all about ready to fall apart on itself. You'll see now in a lot of BVMs, they actually have PEEP valves on them. I don't know, that's actually believe it or not, relatively new. That's something they didn't have, actually about 5 years ago. So, but problem is, again, like I said, with too much positive pressure in the lungs, like I said, we can actually, clamp down on the venous circulation, decrease cardiac output. Too much positive pressure, we can actually cause barotrauma, possibly pop a lung, and may worsen air trapping obstructive disease. You guys, we haven't really talked about how asthma works. I think we're good. I think we will later on a couple slides. But asthma is kind of like, for example, it's one way in, but it's almost that's really about it. And that's what the problem is. Because you can think about like if you had like a tube, okay, like a rubber tube that's flush with each other. If you stretch it down, you can get that lumen to open, but when it snaps back up, it closes. That makes sense? That's kind of that's really how asthma works, except it's in all the different circuits there. So we can get air in because we're stretching down. We can pull it open. It opens that lumen up in that tube. But when we let go, it just all clamps back down. Make sense? So CPAP, again, people without preset ventilator rate and volume. We're just blowing air, keeping pressure in. Understand that the patient needs to be breathing. Please make sure they're breathing, or at least be prepared to when they stop breathing. But yeah, that's a pretty big thing that popped up in the last couple of years with EMS is using CPAP. CPAP, from my personal experience, it's either one, it works really well, or two, you got about 20 minutes to prepare your intubation equipment. I've never seen it just really take anybody over the edge. So high frequency ventilations, again, small volumes, high rates, so we're breathing faster. So at this point, gas exchange allow at lower peak pressures, but look at the rates here. We're going like at 60 to 120. I mean that's we're looking at. We're looking at neonates at that point. I mean that's really what we're. I mean that's really fast.
So what is that machine that I've seen it on a child, and then my daughter's softball coach has actually had it because he had real bad lung problems or got sick and were damaged. But I guess you're knocked out, and you can hear it. It's just like really fast pumping. I guess they're trying to get the CO2 out. I don't know. And I've only seen it twice, and apparently they don't use it very much. And I can't remember what it's called.
I have no idea.
It's attached to them or something?
Yeah, it's for their breathing, but it's so fast when you're talking about like the per minute. It's just, and you can hear it.
I would have no. I have no idea.
When was it? The children's, they had a kid on one.
Yeah. I mean, I could. I'd have to look at it to even get an idea what you're talking about. So, but anyway, high frequency. Again, like I said, severe obstructive disease. We have to worry about issues of barotrauma, the case may be. Obviously, we don't want to rupture their lungs. Who develop ICP with conventional methods. Again, we're not trying to cause more problems here and so forth. And under general anesthesia. So generally, what they try to do is, first of all, they try to figure out what your tidal volume is going to be. And I've seen 5 to 10 to 15 milliliters per kilogram. Some people say standard is 12. Some people say standard is 7, depending on who you read on what day. But ideally, we want to figure out how much volume your lungs can take. That's the first thing we want to figure out. After that, we're going to try to figure out your rate. The rates usually don't actually change beyond this. It's usually like 10 to 16. You rarely ever see it go high. Actually, even more like 10 to 14. That's really about it. If they want to tweak something, they'll either tweak the volume, they'll either the inspiration of they'll kick up the oxygen, or they'll call what the IE ratio, the inspiration-expiration ratio. And that's all it means is a second in, 2 seconds out. Like an ARTS patient, they might actually flip it, make 2 seconds in, 1 second out, kind of a thing. So usually this gets set and gets kind of left. The only thing you ever have to worry about is if they reach a certain pressure, they'll have like an alarm that says pressure here, and it'll actually have a pressure alarm, and then it'll back off, and they'll set the pressure there too. But like I said, these are, so yeah, when we see a vent, usually we want to get this, we want to figure out our rate, and then like I said, do we want to put it on assist control, SIMV, what are we dealing with kind of thing. So other things, you can also inspiratory flow time, humidity, trigger sensitivity, and so forth. Size. Actually, we can actually make the machine perform size, so you can get a good deep breath and keep your lungs open. So, actually, the best thing to do is, you ever heard of the acronym DOPE? Dislodgement, obstruction, pneumothorax, equipment. If you ever run into a ventilator, remember that. So, but the thing is, yeah, the first thing it says, obviously keep the machine functioning. Actually, honestly, when in doubt, if you have no idea what's going on and you're don't know to play with it, unplug it and bag them. Don't try to play with something unless you've actually got a good understanding of these things. Don't get yourself in a bind. some people will be like, oh yeah, they're easy, and it's like, no, these things you really got to play with a few times.
What was the P?
Pneumo. Yeah, that's a big, like I said, that's a big thing when you see on an event. Just remember that DOPE acronym.
Oh, is that for problems that arise?
Yeah, it's either dislodge, obstruct, pneumo, or equipment failure. So now the other thing I want to keep is if you're transporting somebody on an event, and you're familiar with the event, yes, keep the alarms going, because you'll hear a lot of beeps and stuff. But like I said, it just kind of makes you, hey, I got to keep an eye on what's going on here. But when in doubt, disconnect and do it manual. So airway malfunction, suction patient is needed. Keep condensation buildup out of the connecting tubes. So auscultate frequently. Again, like I said, remember you're in a moving truck. You've got a lot of tubes. Things can move around very, very easily. And things are, those tubes are heavy enough to kind of give a good pull. Keep your end tidal. Make sure you got your end tidal so you can see what's going on there. All of a sudden your end tidal goes away. That's a bad thing. So again, same thing. Start troubleshooting right away. Barotrauma, again, you don't want to put high pressures for a COPD. Again, like same thing. It's just you're going to have to reassess. Bad thing is just treat, if somebody's on a vent, treat them like a critical patient. Reassess every 5 minutes. So again, same thing with hemodynamic alterations, decreased cardiac output, decreased venous return. Obviously, we're going to see decreased blood pressure, decreased level of consciousness, decreased urinary output. If you're actually going to see decreased urinary output, that's a very, very long-term transport kind of a thing. And that's what we're talking about. So you got to go with it 0.5 cc's per kilogram per hour kind of a deal if you're monitoring urine at that point. So, and again, like if you're reassessing every 5 minutes, you're going to catch all this stuff really quick. Other things you run into, long-term, renal malfunction, pulmonary atelectasis infection, oxygen tox, respiratory muscle tone, and so forth. But we are not going. The only time we're going to see some of this stuff is they've already been on an event for a while, and we're transporting them. And chances are they probably already know, or maybe it's not even happening. Otherwise, you just got to look for the big stuff. So other things just kind of keep in mind. Just remember, set your PEEP at usually, and actually you can see the same thing goes with your BVMs too. Just start at 5, work your way up. If you feel, and again, like I said, you're looking for oxygenation, especially when you got the end tidal and all that business going on. Sensitivity. Actually, I'm not going to get into this. This is something you really ought to see in critical care, to be honest.
One step before this one. I'm not liking that.
Yeah, this is the big things to get out of here is just understand setting up the, again, like here, now they're changing the tidal volume again. So tidal volume pretty much just goes 7 milliliters per kilogram.
If we're using a ventilator, it's because they're already on it. I mean, right now in EMS, is there anybody that's using them? Use the transport times. Aren't we just going to ventilate them ourselves? You see what I'm saying?
Usually, I would have kind of liked to have had them, to be honest, especially at cardiac arrest.
Mm-hmm.
That's one person less.
Well,
And
are they used right now? Is it something?
It's usually for critical care transports. Is usually all it is.
There's not an emergency calls with it.
What I'm saying is 911 calls. I mean, and those are pretty much.
Did you say you 7?
Huh?
7?
Yeah. You always want to get respirations, usually between 10 to 14. Your PEEP between 5 to 10. Tidal volume, pressure. I wouldn't worry about that right now. That's the ones I'd be worried about. If you ever do a critical care transport for whatever reason to get familiar with that stuff, then yeah. All right, respiratory pharmacology, drugs. Drugs. So obviously nebulized bronchodilators, big ones here, albuterol, Alupent, and so forth. I guess obviously the point is you nebulize it, it covers more surface area, we get more of an effect. And again, these drugs can be kind of a combination between the beta-1s with also the anticholinergics and so forth. It just kind of depends on what they want to do here. So Primarily beta 2. Problem is with beta 2 drugs, they're very rarely purely beta 2. So that's why you see these people, you give them albuterol, next thing you know, they get tachycardic. They're not pure beta 2s. They're primarily beta 2s, but they're not pure beta 2s. So that's why you'll see the tremors, headaches, tachycardia, palpitations, nausea, and so forth. But again, stimulate beta 2, we get muscle relaxation, bronchodilation with that. Generally, with albuterol, 4 to 6 hours, isoethylene, 1 to 2, just depending on the drug itself.
Is one of those more beta 2 than another?
Now,
It's about the same?
they're all beta 2s. It's just depending on
I mean,
dosages.
as far as like the effects on the heart, is one of them, or any of those
Better than the other?
better
No.
than the other?
Are the bottom two used very often? I've never heard of them.
No.
I'm gonna ask. Okay.
So, I mean, there's one, the isomer for albuterol, and I can't think of its name. But those are real pop. Yeah, there's a. The only thing they found out when it comes to beta 2s, the only ones that work really well are the albuterol and terbutaline. Everything else has pretty much had no greater or different effect. So, epinephrine. A couple ways you can do this. Obviously, we can give this intravenously or sub-Q, and we definitely get the beta 2, beta 1, and alpha. Actually, in some places, they may even allow you to nebulize epinephrine, especially if you have like epiglottitis kind of an issue. So you give like racemic epi, but you can actually give epi nebulized too. Obviously, if we're giving epi to somebody who's in respiratory distress, we're trying to blast them quick. We're trying to blast them and open up quick. It's again, hit them with this first, and then we'll come back with the other drugs. Again, adults, 0.3 to 0.5 sub-Q, pediatric. That's not the correct dosage.
Which one?
The pediatric isn't.
0.01.
Yeah, it's like 0.01 milligrams per kilogram to a max of 0.3. Yeah. If you ever actually give sub-Q epi to a kid, let me know. I've never seen it happen. So big one to remember is just the adult dosage right now. Same thing with any kind of, again, beta drug, anxiety, hypertension, dysrhythmia, chest pain. So they say it's contradicted greater than 35. Reality is, if that's all you got and that's what's going to need to work, you're going to have to give it. And of course, even they'll say, well, if they have heart disease or they've had history of MI or case, you know what? You got to make that decision. Yeah.
What is the deal with 35?
Greater risk for heart disease.
Yeah.
Just in general?
In general.
You need the same thing as cardio heart. I mean, you're back to normal. So.
Yeah. It's just yeah.
So that greater than 35 is more of a relative.
It's all of these are relative, because I mean, if they're again, like you're saying, if they're anaphylactic, what are you going to do? Sit back and do nothing? You're going to have to sit there and blast them and say, I hope this doesn't kill your heart too bad. You got to take care of it. You can't get away from it. So, terbutaline. This is a nice one you can give sub-Q. Again, same thing. This is actually good for contractions, by the way. Smooth muscle relaxer. But same thing, just give sub-Q. Works really well.
Can you give it any other way? I was just wondering,
Yeah.
like, if you gave epi and then you already had an IV started, would it matter? Like if you gave epi like sub-Q or something, and then you got a line started, could you just, why stop?
Give it IV. You're talking about then give it
Yeah,
IV?
unless I'm saying give it like IV. Like
Well, hopefully, once you give sub-Q and that took care of the problem. I mean, it happens. You get refractory, but usually if you give sub-Q and it bounced back, just stick with sub-Q. If it's just, if they're shut down, you had to give them IV. I mean, I've heard of cases where they've had to give repeat doses of that, but
That's
it's rare. So yeah, just keep an eye on the adult dosage. Pediatric dosage, again, 0.01 milligrams per kilogram up to 0.25. Understand once you get to the adult dosage you stop right there. So, but same thing with any other beta 2 tremors, headache, nausea, vomiting, et cetera, et cetera. The other one here, Atrovent, anticholinergic. Big thing with Atrovent, make sure they're not allergic to peanuts or soy, because that's how the drug is made, what the drug is made from. Thing about Atrovent is you give them one dose, it lasts for like 8 hours. I mean, that's all you need. It's not, more doses isn't going to help you at all. Now, the couple of schools of thought of this is that some people say give an albuterol and then go back to an albuterol and Atrovent, and then you go to the hospital. What do? Give the albuterol and Atrovent right away. Yeah. It's the Atrovent is not going to really harm them, to be honest. It's just more of medical director preference versus the other. So, but yeah, realistically, you can just give an ANA and go right from there. But Atrovent just works on the smaller airways versus albuterol works on the larger airways, and that's why you're given this drug. So, and again, you can give meter dose inhaler or small volume neb. You know, again, obviously we can mix it with the albuterol at that point. Same thing. Again, it's anticholinergic, so the thing we have left is some pathomimetic system, and of course we're going to get all these other things, except we're going to add drying of secretions, which anticholinergics do. So, of course, some people argue, you know, be careful of giving anything that can dry secretions to an asthmatic. But I'll say one thing: if you're having trouble breathing, or if they're having problems breathing, it's not working, give them the drug. So the other one here is the methylxanthines. You know, pretty much it's just high dose caffeine. And here we got amyophyllin. Amyophylin's pretty kind of phased out. You might see somebody just for whatever reason put on amyophyllin, but again, it's just like I said. I mean, it's, you know, again, we're pretty much using caffeine. We stimulate. We got a catecholamine dump. We're getting the same effects all over. We're just going to getting the same effect, different route to get it. Make sense? So, but yeah. Get all this? Don't worry about it. So, indications again, strong dilator, asthma, status asthmaticus, COPD, anaphylaxis, congestive heart failure. Again, you get that nice catecholamine dump. So loading dosage, 5 to 6 mg per kilogram. And we can put a maintenance dosage. Like I said, this is so rare. But this is actually not. I don't even know if this is even given in the field anymore. Usually, it's just, like I said, I wouldn't be too worried about it. So, again, medical history must be obtained. Just be careful. Reduce dosage, severe CHF, COPD, liver disease. You know, avoid anybody who's on theophylline because you're going to really amp them up at that point.
Is it something that is still prescribed?
I don't even know if if it is, it's so rare.
Okay.
It's a very.
So it's not just in the trucks; it's in general.
Yeah, those were the methylxanthines were the first line drugs years ago, and what happened was that we started getting these steroids, and it wasn't just steroids; we got inhaled steroids. Inhaled steroids actually did a lot more good for all these respiratory diseases than the methylxanthines did. So the methylxanthines got kicked out of the way really quick. The steroids took away all the inflammation, took away the inflammation secretions. What do you need the methylxanthine for? Now we just need the rescue inhaler. So, again, like I said, steroids act directly on inflammation of the cells that cause the reaction, because that's what a lot of respiratory asthma, COPD. When you get those respiratory distress, is what you're going to be dealing with. So, the nice part is that it's usually a very nice long-term fix. So, and inhaled steroids actually reduce a lot of the risks that you could get with steroids. Obviously, you can actually, like the weight gain and so forth, and actually, with taking too many steroids, you actually cause your own body to actually decrease the secretion of its own cortisol as well. So, like I said, inhaled steroids actually gets rid of all that problem. So again, some inhaled steroids, Flovent, Asmacort, and so forth. These are usually taken generally on a daily basis. You know, the only thing they usually worry about is dry throat, irritation, thrush. Have you ever seen thrush? It's kind of nasty. But so worst case scenario, they'll actually give you oral injected. Usually, if we're giving you, that's the ones we'll usually give, oral steroids. And the idea with oral steroids also do is they actually upregulate the beta-2 receptors. So we'll actually get more beta receptors coming up. So when we start dumping albuterol and the albuterol is coming in, we'll get a better reaction out of it. So that's kind of one of the reasons why we'll give steroids in conjunction with whatever it is we're treating. I understand ideally, though, get the big guns out first, get the albuterol, get the atrovent going. Worst case scenario, get the epi going. We can back it up with the Solumedrol or Decadron or Pendrazone, whatever it is you're doing up down the road. So, problem is, again, with long-term use, obviously with steroids, you get the bone thinning, reduced growth, high blood pressure, weight gain, immunodeficiency. Like I said, it's too much for a body that would normally handle, plus whatever we're making. And then, like I said, if the body starts seeing there's all these other steroids in here, it's going to quit making its own steroids, and then these guys have to taper off, and it can be a mess. I mean, depending how bad their disease process is. I mean, these guys are like kind of up and down all the time, trying to make a balance game out of this. So, sodium chromoglycate. I haven't seen much of these out. And all of these are just, like I said, it's just kind of, just stabilizes the leukocytes, And like I said, we stabilize the leukocytes. We're actually just stabilizing the actual immune reaction is all we're trying to do at that point. Leukotriene antagonists, again, like I said, these are the chemicals released by the leukocytes at that point, and they just block the leukotrienes. And a lot of times these guys will actually you might actually run into them, they'll feel a little bit dried out. So you actually can get a little bit of a kind of a backdoor anticholinergic effect, and which is what it's supposed to do. Because like I said, we stop the inflammation, we're not going to stop. We stop all the gooiness and the coughing up stuff, but these things actually work really well. So. And again, here's your examples. Neuromuscular blockers. Here's a good fun one. So, by the way, why do we use neuromuscular blockers, really? Yeah, we're going to breathe for them. We're at that point saying, you're going to stop breathing, you're going to lose all your oxygen reserve, you're not going to make it, we're going to beat you to the punch. We're taking your license away to breathe. For whatever it is, or you're not breathing and we have to breathe for you here. Obviously, head injury, we're concerned about seizures, status epilepticus, that could, burns. Like I said, we have to, in other words, whatever reason, maybe you're not ventilating effectively or breathing effectively, we're going to take over and do it for you. But again, like I said, we paralyze them. That's all we're doing.
Stop movement for diagnostic studies. So we can RSI him to get his one lead for shaky. Sorry, I'm about to knock you out your movement.
Tell me how that works out for you.
It just said on there.
Just tell me how that works out for you. Who's your preceptor?
I don't know.
I'm gonna find out about that.
Well, it said it. I'm just saying it.
This is one of those you can do anything once, and I really want to see this one. So you guys remember how depolarizing neuromuscular blockers work? You attach to the receptor sites, basically polarize the muscle. You'll see the fasciculations, little twitching, and that's it. So no antidotes. The thing is, a lot of times we use sucks because it's only going to last about 5 minutes. The other ones here, the non-depolarizing, like I said, just lock on the receptor sites, block the acetylcholine, and then that's just it. But the nice thing is we can use some medications here to reverse it, the neostigmine and so forth.
The non-depolarizing just keeps it from repolarizing, right? Once it depolarizes on its own, it keeps it.
Actually, you can just go straight. Believe it or not, you can go straight to non-depolarizing if you want to. The reason why we use sucks is because
it's fast acting.
It's
short. Right?
It's short acting.
But if you have a reversible drug, then why not use that?
Because you usually don't keep this on the truck.
Oh, okay.
That's why. I think there's another one. I don't know if it's pancuronium or rocuronium that's non-depolarizing that has a short act. Because I know they had a succinylcholine shortage about 2 years ago. But incorrect use, loss of airway, and death. Yeah, make sure you've assessed your airway and making sure you're going to get this tube. Or have at least plan B and C ready to go. Because, like I said, it's going to look bad when they die. And, there's going to be a lot of questions and
Try
paperwork.
not to be distracted after you push it, though.
Yeah.
Find something else to do.
Yeah. That's a nice way of putting it, yeah. So, other thing is neuromuscular blockers, understand they do not snow you out. They stop everything. You can be very, very nice and conscious. And usually the big giveaway when you realized, and I actually saw this in the hospital, well, somebody gave the neuromuscular blocker and they didn't give the induction agent. Next thing you know, you see the patient with tears streaming. That's the big indication you screwed up. That's the big indication you screwed up, okay? So you got to remember that whole induction agent. We want them to forget about this event. So please sedate first.
Or you know what happens too, that's gonna suck. I mean, it's gotta happen, you know? Like, eventually, you know, somebody's gonna screw up somewhere.
Oh, it's happened. It's happened intentionally, I can tell you that much.
That's even more messed up.
Yeah, there are some not so nice places to work in this country, and you don't want to be on their bad side. Yeah, I mean, honestly, if you really snow them out with something that's really good, like Versed or something like that, you're probably going to get that tube in there before you even realize it, and they won't even realize it. Then you can give them the succinylcholine. I mean, if you really play your cards right. I mean, I know it goes against the RSI purpose, but like I said, you give them enough Versed, it doesn't matter. So, and again, sucks 30-second onset, lasts 4 to 10 minutes, fast in, fast out. The only thing you got to worry about is you may cause hyperkalemia, especially with burns. Especially with burns, we've already got all the burned cells, so we got a lot of free-floating potassium as it is. And of course, when we give sucks, we depolarize and we're kicking a lot of potassium out to begin with. So just kind of keep that in mind. Twitching can displace long bone fractures, could increase intraocular pressure, again, more twitching, you know, and transient ICP and so forth. So the only thing you really need to worry about with sucks is the malignant hyperthermia, and unfortunately we don't carry dantrolone on the truck. Dantrolene. So that's the only thing. I mean, problem is once you hit something like that, you're kind of SOL. Not unless, like I said, they actually carry it.
I keep seeing the malignant hyperthermia. What is that?
They,
I know what hyperthermia is, but what does it mean? It just
they burn hot really fast. They're cooking.
just for
No, they're-
whatever reason, it just happens?
Reaction of the drug.
Okay.
Yeah.
Would you just like try to put, I mean, I know that's very minimal effect, but just put ice packs in your groin and neck? And
Everything you,
anything
yeah, pretty
you
much.
can do?
Everything you can, dry faster.
Does a medication increase metabolism or something, or they're cranking out a lot of heat?
I'm not really sure, to be honest. I'm not sure if it's an actual metabolism issue or an actual just reaction to the medication itself. So, pancuronium, again, 30-second onset. Problem is, this is a long-time commitment, 40, 60 minutes. So that's the only thing you have to really worry about. Give it, you're trapped with it. VEC, again, nice thing is kind of we use this usually in our size, kind of the more follow-up once we've successfully intubated with sucks and Versed, and we give about 20 minutes, and like I said, we can kind of just monitor from there. Rocuronium, 3 minutes. 30 minutes. They're intermediate acting, so may or may not result in hyper or hypertension. Again, depending on the reaction. Big thing here. Remember we talked about. Always prepare. 90% of all this is all preparation. Make sure you get all your equipment ready to go. Everything ready to move smooth. So by the time you push those drugs, it's going to take you about less than 30 seconds to put that tube in, and everything's good. Because the last thing you want to do is start digging for equipment, and you're like, well, where's my laryngoscope blade? Oh, I guess I should have got that out. Oops. So again, pre-medicate. Give the induction agent. Give the Versed. You give lidocaine if you think there's an ICP issue. Give atropine if they're a child. We don't want to have issues of reflex bradycardia. Intubating them can cause reflex bradycardia. Again, sucks 1 to 2 milligrams per kilogram. We know about with us. There's no end limit to sucks. There's no max dosage. So intubate. Make sure maintain adequate neural blockade. Make sure they're completely sedated and so forth.
So what does the lidocaine do for the brain injury? Increase ICP? Just slow anything down?
Lidocaine.